right, so hey everyone, I'm Diane. I'm one of the pediatric emergency medicine attendings in New York City. Let's see, we are at Mount Sinai Beth Israel in New York City. So we're excited to be hosting this session entitled Incorporating Communication Objectives into High Fidelity Simulation. We have four amazing panelists, and I will introduce each person separately. They will have a couple of minutes, 5 to 10 minutes, to talk about their work and hopefully be able to display some of their stuff on through share screening. And then once they're done talking about their work, we'll open up the forum to our audience to ask questions, etc. All right, so we will start with Dr. Sarah Hawk first. She is an ED simulation director at Rush in Chicago and an associate professor of emergency medicine. She teaches at the medical school and is the director of assessment there. She was also one of the founding faculty members for the EM Rush residency that started in 2017 and continues to teach the residents during bi-monthly simulation conference there. She has a ton of different curricula to talk to us about today, but I asked her to focus on just one. And so she's going to be talking about an interdisciplinary simulation with security involving a suicidal patient and how to de-escalate during a high tension situation.
Hi, everyone. I'm excited to talk about this case and this topic in general and hear what other people are doing, because I can always use pearls from other folks to add to my own sims. So thanks everyone for coming and speaking. Is it possible? Let me make sure I can share screen. Yes, thank you. So I'll share with you the case and you can peruse as I'm speaking. It's always also helpful to me to see how other people organize their thoughts when they're creating a case for their learner, because there's a lot going on when you're trying to execute a case, and making sure you have all the details can be really challenging, especially if you have less experience putting together all of the parts of the simulation case. So to tell you a little bit about this case, the goal here was to practice actually coordinating with our security team and our nursing team at the same time with our residents. So we did this during resident simulation conference, and you can see the objectives here, and then I'll show you where in the simulation case they're incorporated. So clinically, the physician, the residents are supposed to recognize escalating behavior. They're supposed to order the dose, route, and type of medication that they feel like the patient requires, and then assist with proper 4-point restraints. So if any of you have residents that happen to know how to put on 4-point restraints, awesome. Our residents pretty much don't know, but may need to supervise it in their clinical roles going forward. So that was one of the objectives, was for them to be handed a restraint and say, please do this. And then in that non-critical situation, learn how to use it with the help of nursing staff that were embedded in the scenario to help them. But there were also these behavioral or communication objectives here in the case. So you can see we hoped that the residents would try de-escalation techniques, as you would in a clinical scenario like this, to communicate with security and kind of indicate what's needed from security, and then maintain their safety, security safety, nursing safety, as you would in any of these types of critical situations. So you can see kind of the vignette to give the background information to the people portraying the case. And we actually utilized a live actor in this situation. It's possible to hire an SP. We actually used one of our MAs from the psych preferred area of our ER. So she had seen a lot of these events happen and felt comfortable putting on the paper scrubs and portraying a patient in a way that allowed our team to learn. So this was maybe a medium fidelity type of situation, because we were located in the emergency department in situ with the stretcher and all of the clinical environment around us. We weren't using a high fidelity mannequin, and I don't believe this patient had dynamic vitals, because we don't usually have our psychiatric patients on a monitor. But we often, even with a live patient, will use dynamic vitals on an iPad or tablet type device. So the main kind of vignette is this patient has aggressive behavior and is being told that she's going to be admitted involuntarily, and then escalates and becomes aggressive, which is something, that's an inflection point that often can result in aggression, as we all know. So attempting to de-escalate and then call for security. So you can see kind of the details of the patient, and you could put as much or as little as you want in this particular template, which is the template used by the Rush Sim Center that we've adopted in the emergency medicine department as well. Really, you can see this case, we didn't put the dynamic vital signs in for the purposes of the case, but you would be able to if you needed that information critically. Because it wasn't relevant here and we weren't using it, we didn't fill it in. But in general, the patient responds in an agitated way, and the residents are expected to recognize the escalating behavior. So you can see here, this is that first objective. Positioning themselves relative to the patient such that they are safe is something that our residents don't always find intuitive. So it's something to give them feedback on. Did you step closer to the patient or slightly further away to prevent harm to yourself from an agitated patient? Did you instruct the nurses potentially to step back if necessary? Here's to give the verbal orders and call for security. And then work with the nurses to prepare the 4-point restraint administration. Embedded in this case, security, we had actually 4 or 5 security available because our security department felt that this was an important case for them to participate in for their learning in the interdisciplinary format. And so they came, and each security team member restrained an extremity, which I know doesn't happen in every emergency department. Luckily, it does in ours if we really need it. And so the patient security works with the nursing staff to restrain the patient. And then one of the objectives is actually that bolded one: security may improperly restrain the patient. And I worked with one security person to say, you are going to improperly restrain the patient. And then the patient knew it was coming. So the patient said something like, I'm having trouble breathing. And then the resident ideally would recognize that that was an improper restraint of the patient and correct the security team member to help resolve that for the patient's safety. So those are the objectives that we had going through the case. And then ultimately, as we were, let me see what I have, just kind of the other parts of the case so that you can see our template. Having embedded simulated people, the patient, nursing, residents, and security were all involved. And then here are the objectives. And often you would kind of add, in our case, we would add at the end if there were any salient debriefing tips. In general, the main discussion in this case was how security and nursing could interface, how to use the restraints, how to recognize and help security effectively and safely do their job that we're asking them to do. So it was a lot of communication and a lot of learning from the security perspective, what they're taught and how they know to do what they're doing, and how we can learn from them. And so our security team was very forthcoming on, this is what we know, this is what we have been taught, and this is how you can help us by telling us what you need. So I think that's kind of an overview of how we used communication objectives in this case. It required a lot of collaboration between our nursing assistant and our nursing staff, as well as the security office. I probably emailed them 2 months in advance to say, hey, is this something you're interested in? And then they overstaffed that particular day, so the security officers were available in the emergency department for our sim. So that's what I've got. Thanks.
Oh, thank you. That was a really cool case. All right, so our next speaker is Dr. Aldalati. She is one of the simulation fellows at Brown Emergency Medicine in Rhode Island, and she is working in the Lifespan Simulation Center there. She has a personal interest in tele-simulation and diversity, And so right now, the curriculum that she is working on is for their DEI group, and is incorporating communication skills into the sessions that she's creating for them. And so then she'll tell us a little more about it.
Hello, everyone. I'm really happy to be here, and I'm really happy to share some of the cases that we're working on. It was a little challenging because those cases are a little like dear to my heart, but I picked one about religion. I'm sorry I don't have visual to share as the case is still in progress, but I can tell you the scenario and what's going on. So this is a case of a 60-year-old female who is a Muslim who lives abroad and is visiting her family. She comes in with chest pain to the emergency department. This is a case where the patient has metastasized breast cancer. Family are aware, but they did not tell her. She does not know that her breast cancer is metastasized. She's thought that she is in remission and she's cured, and she comes in with this chest pain. So in the scenario, there's two actors, the 60-year-old or an actor who is for the lady, and then there's two family members, two sons. Those sons, like whenever you try to take a history from the patient, they interrupt. They would not allow you to speak in, like, mention anything about the breast cancer. They try to pull the learner aside and try to ask them to not tell her. It's a challenging case for the learners because they would not expect, the SPs to act like that. They would not expect to be pulled outside the sim room. Ultimately, the learner has to sit with the two SPs, like, hey, we gotta tell your mom, like, we can't hide this from her. The lady would have PE in addition to her metastasized breast cancer. The other challenging part of this case is the lady is a hijabi, so she would not allow the male residents to examine her or to expose her excessively, and so they would have to deal with that as a barrier. They would have to explain to the patient that we need to examine you, like, this is going to be brief and we're going to cover you up again. And the final barrier to that case is it's going to be during fasting period during Ramadan. So the lady would refuse any IV medications, would refuse any oral medications because she's fasting. And that's another aspect in which the learner will have to acknowledge her decision, explain to her that she needs this. And then try to seek further resources. Like, we do have religious resources in our in the lifespan center, so they can ask to speak with the sheikh or imam, whoever the person is on call, so can explain to the patient that this is actually allowed in their religion. It's a challenging case for the learners because it has multiple barriers. The debriefing for this case has been but every group is quite different because each group not all groups reach to the final stage with sitting with the sons and explaining to them. But it would teach the learners how to look into patients from their perspective, because not all patients are the same. They have different views, religions, and backgrounds, and it would teach them how to communicate with these patients. The nurses found this also helpful because when you have a nurse, it's not a nurse will be one of the group as a member of the group, not as an embedded learner. When you have a nurse in there, it's a different perspective for nursing because nurses are used for patients in gowns and hooking up to the monitors right away and whatnot. It's a different experience for the nurses, and they would appreciate that as well. That's in brief all I got.
Oh, thank you. All right, so next is Dr. Maggie Putton. She is the EM Residency Director of Simulation at Advocate Christ Medical Center in Chicago. She implemented an EM palliative care curriculum for the residency, incorporating communication skills with SBs and high fidelity simulation.
All right, thank you. Yeah, I'm happy to talk about this with you guys today. Let me see if I can share my screen. Sorry, I'm really like tech illiterate, but let's see. Can you see? Okay, great. So this was part of our palliative care curriculum, which we just implemented this year. So this case was intended to be sort of putting it all together. So the curriculum itself consisted of lectures, a communication skills lab with SPs where we had them rotate, and it was strictly communication skills. And then this case was sort of a hybrid of a high fidelity sim and still communication skills. So the objectives were primarily actual communication things in terms of like delivering bad news and having goals of care conversations. And then there's a medical component to it. So I'll just kind of show you our structure here. This is the Advocate Aurora's template that we use for simulation. So the objectives for the case were to utilize the ask, tell, ask technique, to employ a headline for delivering news, to utilize nurse statements in response to emotion, to utilize open-ended questions to elicit the patient's goals and values, to make a recommendation based on the patient's goals and values, and then interpret and utilize surrogate decision-making laws and apply them to shared decision-making. So now I can talk more in detail about these like ask, tell, ask, and headline and nurse statements in the bottom when I show you my debrief. So on our template, we have debriefing points next, but I put my debrief thoughts at the very end, so I'll show you them. And then we have a pre-brief here. So this is what I would tell the residents before the scenario starts, essentially that this is part of our curriculum, and it's a formative learning experience, and the basic assumption. And then we get into some details about the patient. So this patient is a 65-year-old female. Her name is Terry. She's 70 kilos, hypertension, high cholesterol, her meds, et cetera. And then this is the prompt. And actually, I really just said this is a 65-year-old woman that was brought in from EMS because she was found unresponsive at the mall. She was there shopping and she collapsed. And then the paramedics brought her to the emergency department, and she was unresponsive en route, so they intubated her. I didn't tell them, I have it listed here that the Jehovah's Witness card is in her wallet. But I incorporated that actually a couple minutes later into the scenario. So the quick summary is that this is a woman that is 65 years old. Like I said, she's a Jehovah's Witness. She collapses at the mall, and she's unresponsive. So she's intubated, she's brought to the emergency department. When she gets to the ED, she's hypotensive and tachycardic. And then in her wallet, she has a Jehovah's Witness card that says that she would not accept blood products. And like I said, she's hemodynamically unstable, and they quickly determine that she has a critically low hemoglobin of 2. So the first part of the communication skills is that they need to reach out to a surrogate to find out if she would accept blood products or not. And so that is, I kind of have it down here in my summary of what happened. So they call the patient's surrogate, who is her spouse, to discuss this card and find out if this is in line with what her values are. He confirms that they've discussed this many times and that she wouldn't want to accept blood products. And he understands that she could potentially die or is even likely to die without receiving blood products. And it's in line with their values. So then the residents continue with the medical management as best that they can, including a workup for where this bleeding is coming from. She's been having vaginal bleeding when they get further history from the husband. And so the second part, in terms of communication, is after the husband arrives, they have to discuss the results that they found, and they order either a pelvic ultrasound or a CT abdomen, which shows signs of malignancy. So once the husband arrives, which would just be based on timing, essentially, once the medical residents are done with their workup in the emergency department, I would say that the husband is here now, can he come in? So then they would have to deliver news and then have a goals of care conversation about moving forward. So what I have here, like this summary of what happens to the patient, is not typically this long in writing. What I have in here is also a lot of details for my actor, so that he can answer questions for things about his wife in terms of like what her health has been like recently, what is important to her in terms of family, hobbies. There are specific questions that they kind of teach you in palliative care that you can use to ask about patients' values when you're going to make a values-based recommendation for treatment moving forward. So that's why this paragraph is so long. It has so much information to hopefully help my actor be able to answer any questions that the residents might ask. So anticipated actions and interventions. The patient is already intubated on arrival, and you don't have to do it this way. I did it that way just because I wanted to have more time to focus on the actual communication skills. But depending on how much medical management you want to do, you can have the residents have to perform the intubation. Fluids are not going to make a big difference. So that's why this is written here. Residents may give IV fluids, but no change in heart rate or blood pressure. If they start vasopressors, her blood pressure will improve and her heart rate will go up a little bit more, but really no other physiologic changes. So there is not a lot of dynamic vital signs in this case either. And then really just residents will contact the surrogate after finding the card, which we did by having them call first. Our actor, who's one of our sim staff, was just in the control room to answer the phone. And then once they finished their workup, then he came into the room to have the conversation in person. And we have our scenario flow, which just has like opening vitals. So here, like her heart rate's 140, her pressure is 70/40. And then after starting vasopressors, I pushed her blood pressure up a little bit, but really those are the only vital sign changes that happened during this case. So this is our just sort of like information for my sim team about what I need. And then I have references here. So this is where I keep all the information about my like lit review basically for preparing the case and my debrief. Here are some stimulus things that just have the labs. And the patient's hemoglobin was 2, by the way, and then the pelvic ultrasound and CT results looking concerning for malignancy. This is a copy of the Jehovah's Witness card. So we had this printed to hand to the patient. The RN says like, oh, I just found this in the patient's wallet really early in the case so that they know right off the bat not to start blood products. This is notes for the Confederate playing the family. This is more notes, just mostly about the medicine, because the person who's playing your actor doesn't necessarily know everything in terms of like their medical background. So this is really more just about what it means to be hypovolemic shock and losing blood and things like that. So I think that's optional. And then my debrief notes. So this is like my little template, the communication skills. This is just, I say this at the beginning of my debrief, like these are my goals that I want to cover with you while we're talking here. So number 1 was the communication skills. Number 2 is sort of the ethics of giving blood transfusions or refusing blood transfusions, determining decision-making capacity. So that conversation is part of it, a surrogate decision-making hierarchy, and then the medical management of anemia and the Jehovah's Witness, which the residents all really want to talk about, and it's important too, but again, the priority for this case was really more about the communication skills. So the structure that we were teaching for the goals of care is called REMAP, which is commonly used in palliative care and like ICUs. I kind of use a slightly more concise version of this, but this is really the structure in terms of goals of care conversations that I've been teaching them. So using the ask, tell, ask technique is basically like, is it okay if I tell you what I know? And then the patient or family member says yes. You give them the news, and then you ask again if they understood or if you were clear. Does that make sense? Something along those lines. And using a headline to deliver the news is a big point of emphasis for this training. So a headline means delivering the news in a clear, concise way with like as little medical jargon as possible and really concise, like I said, and then also including the meaning. So I have this picture here just for a reminder for myself of this headline of 1,500 dead in Hawaii, Congress votes war. So, I think sometimes, at least, I don't know if you guys do this, our residents sometimes have a tendency to tell the family or the patient news in a way that's almost like they're presenting the case to a consultant or a colleague, where they say, oh, you know, your wife was at the hospital and she collapsed and we found bleeding and her blood counts are really low and now she's on a ventilator and she's not breathing on her own and her blood pressure is really low and her heart rate's really high and we're really worried about her. And it's kind of all just going over the family's head or bouncing off of them, and they're like, huh? Okay. So I was trying to emphasize the importance of delivering a headline, which means being concise and delivering the meaning with that. So the headline might be something like, your wife has lost a lot of blood and she's critically ill. I'm worried that she could die. And really including that phrase of, I'm worried that she could die. That's the meaning part of it. And so you deliver that news using a headline, and then you kind of wait and expect that if you delivered news with a headline that landed, then there's going to be an emotional response. And so the next part of the remap structure is E, expect emotion. And if you don't get an emotional response, your headline probably didn't land. And the other thing I'll say is that a lot of the emotional responses, sometimes we think what's happening is that they want more medical information. And in fact, that is an emotional response. They start asking a lot of questions. How is this possible? What do you mean? But really, they're processing and this is their emotion. And we start wanting to explain to them and emphasize like, oh, they just don't get it. And we just keep nailing those details by why medically this is what's happening, when in fact, they just need us to acknowledge the emotion and help them process the emotion for a minute, and then they can move on. So that's the E, expect emotion. And like I said, I talked about the nurse statements. So nurse is just a mnemonic to help you remember some ways that you can acknowledge their emotions. You don't have to do all of them, and it doesn't have to be in this order, but you can name the emotion, like, sounds like you're really frustrated, or I can see you're really upset. You can express some understanding. You can show respect, say something supportive, or explore, just, can you tell me more? And once you do a couple of nurse statements, they can usually calm down, and then you can move on to the next thing, which is map out values or big pictures. So essentially asking about what's most important. Are there certain unacceptable qualities of life, or have you had previous experience with illness? Anyway, asking these questions to understand what is really important to the patient and the family, and then aligning with them to say, what I hear you saying is this, it sounds like this is the most important thing, and then making a plan and really emphasizing that in that plan, we should make a recommendation based on values. So instead of laying it out like a menu of, here are all the things we could potentially do for your wife. We could do CPR, we could do intubation, we could put her on a ventilator, we could give her a blood transfusion, we could put a central line in her neck, we could start her on medications, or we could start her on blood product, all these different things. Like, we have a tendency, I think, especially when it comes to end of life stuff, to lay it out like that and then just say, you choose. It's all totally up to you. And so what we're trying to emphasize here is find out what's really important, what do they value, and then make a recommendation based on your values. It sounds like it's really important to you to be able to be at home with your family and be able to communicate with them. And so we would recommend, keeping your pain controlled. We'll give you medications, we'll keep your nausea controlled, we'll get home health care at home. And if you get sicker, we won't put you in the hospital, or we won't put you on a ventilator, that sort of thing. So that's kind of a quick summary about those communication skills. And that's mostly what I was trying to emphasize teaching with this case. And again, it's part of the palliative care curriculum. So the other points, we talked about that stuff first. And then the other points that we went over are just like the surrogate decision maker hierarchy in Illinois, which is similar in different states, but it's different state to state. How to determine decision-making capacity. And then lastly, the medical management for severe anemia in the Jehovah's Witness patient or another patient refusing blood products. So I think that's it.
Oh, thank you so much. That was a very cool case. All right, and then our last speaker is Dr. Hilary Moss. She is an EM attending and the Assistant Director of Simulation Education and the Director of PA and NP Education at Montefiore Medical Center in the Bronx. Last year, she created and also ran a palliative care curriculum based in simulation, with some of her objectives also having communication points. So we're excited to hear her talk.
Yeah, I'm having some technical difficulties, so I can't actually share any of the cases. But basically, one of my residents approached me, was very interested in palliative care and really wanted to do palliative care sims, and it kind of blossomed into this whole year-long curriculum where we worked with some of the palliative care attendings in our hospital and kind of came up with like 7 core topics that we felt were really relevant to emergency medicine doctors. Some of which were like delivering bad news, goals of care, end of life, cancer complications, things like that. And then we made cases for each of those topics. And so like probably like once every month or two, there would be a palliative care lecture, and then whatever case lined up with that lecture would happen the same day to kind of reinforce whatever topic we were going over. So when we were writing the cases, we kind of wanted to have like a bigger piece of like medical management within the case to keep the entire group of residents who were involved in the case, because I found that when it was just communication objectives, that whoever's doing the talking is like really invested and involved, but everyone else is kind of just standing there like waiting. So we felt by having that cases that were like medically intensive but also having like some piece of it be this communication piece, that we could really harp on the communication in the debrief and kind of go through like ways to approach it, but also have everyone be involved. So one of the cases was delivering bad news. It was a 4-year-old who comes in with a headache, who ends up going into status epilepticus, needing management of like pediatric status, having to be intubated, and then on CAT scan found to have a brain tumor. And so then having to tell the mother the bad news and kind of like work her through that. And we had we would try to have palliative care attendings with us for the debriefs to kind of help go through like their approaches to communication, but also like we had like for like delivering bad news, we used like the spikes mnemonic, which it's been a minute since I looked at it, but basically, S is setting. So trying to find like a comfortable place to talk, trying to get them out of like the loud, crazy ER if we can. P for perception, like trying to see like what they already understand about what's going on, just so that you guys are on the same playing field before you start telling them the news. And then I, invitation. So kind of like asking them if it's okay to tell them, to talk to them and let them know what's going on. And then K for knowledge, basically saying like, I have bad news, to give them a warning shot so they're prepared for whatever it is you're about to say. And then telling them what's going on. And then E for emotion, empathy, kind of giving the family space, trying to respect their feelings, expecting that there may be a wide variety of emotions that come out of the family when you're talking to them. And then S is coming back to summarize with them after they've had some time to process. And so that was one case, was delivering bad news. There was one that was like a death notification. That was like a traumatic arrest that comes in with unsurvivable injury. So they have to run the arrest and then call the code and then tell the family. And then there was like a terminal extubation case. There was like a couple of like hypercalcemia of malignancy, or like severe cancer pain, or a sickle cell patient who was coming in with severe pain and things like that. And we kind of just like ran it over the year, like periodically with them. They seemed to like it mostly. And that's really all I have. I'm happy to send them over for you to share. My computer is being finicky right now.
Thank you everyone for sharing their cases. So we'll open it up to everyone else to ask any questions that you may have of our panelists. Erin, could you potentially highlight our 4 panelists so everyone can just see them on the screen? Try working on that. Well, I'll ask the first question. So for a lot of your guys' cases, you guys mentioned having standardized patients. For the people who have standardized patients, how did you guys find them and have the funding support for them? And then for the people who used other people like MAs and like I think someone had the simulation tech, because there isn't like a whole lot of dynamic vital signs that they could answer the phone and come in and be the family. How did you guys decide to like incorporate these people?
Go ahead, Maggie.
Okay. Yeah, so we did standardized patients for our communication skills lab. I got funding through the residency, I basically just approached the program director and asked if this would be possible. And she said, you know, we have a budget, we often don't hit it. Let's just put this out there. I'd rather do it and then ask for forgiveness later. So that's how we got that. And Advocate has a company that they typically work with. And so I reached out to them in order to hire the SPs. And then for that communication skills lab, we had 3 cases that the different actors were going to be doing. And I sent that to them about a month in advance. And then the company is the one that like trained the actors. I'm also going to be doing a communication skills lab at AAEM in New Orleans in April. And so I am working with Tulane, the medical school, to hire SPs for that. So that was actually, once I found out where to go to hire them, it was a simpler process than I expected. I was a little intimidated by it, but it's really not that bad. And then for this case, I knew that I wouldn't have more money to do SPs, and this was going to be taking place over several weeks. That's the way our sim curriculum works, is the residents come down in groups of 3 over the course of like 4 to 6 weeks to complete one case. They do it during their conference time. So that's why I worked with the sim tech, and we have 2 sim techs at Christ, and they so I kind of wrote it as if either one was going to be the spouse and then the other was going to be the daughter, depending on which sim tech was working that day. But they've done this for me for other cases too. I've done a delivering bad news, like a death notice case in the past as well. So and I have a good working relationship with them, so I just made sure that they would be comfortable with it. And then you saw I wrote this like comprehensive background information so that they would have a lot to read, and then just a lot of, it didn't even require a lot, but, you know, emails back and forth and talking to them in person just to make sure that they felt comfortable answering any questions that might come up. And then, like you mentioned, it wasn't a super high fidelity case. So the tech did have the, you know, bandwidth to be able to make the small vital changes that were necessary and then still be able to do the rest.
So I'll answer next. That's very interesting to hear that there's a company that trains SPs for you when provided the cases. That's a very interesting model. We, in the overall sim budget that I have, I've tried to prioritize the high fidelity as part of our budget, so that leaves less space for standardized patient funding since it is moderately expensive. So because I actually incorporate a large amount of communication into the sim curriculum at Rush for the residents, I actually usually use faculty in low fidelity simulation cases. For example, like, oh, you want to leave AMA, but your troponins elevated. Let's talk about that. Practicing those words is challenging for the residents, but the faculty can easily step into the patient's shoes because they've had that conversation multiple times, probably for each of these types of conversations. For the low fidelity sim communication skills, I use actually faculty. And then for the interprofessional one where we used an MA, I really did meet with her like once or twice before the session to make sure she was comfortable, really like putting on the paper scrubs, which not everybody would be, and like being, you know, subjected to the 4-point restraints is not something that everybody is comfortable experiencing. So that was something that she, you know, did to help us out, and it was really a good learning experience for everyone. But I can absolutely see how, depending on the scenario, it would be very challenging to have someone who's not a trained standardized patient engage in the situation. Examples that I have thought of that are more challenging are experiencing challenging racial situations related to racism or you know, microaggressions or things that could actually traumatize your person that's portraying the patient, or in the case of delivering bad news, asking someone to do the case 6 times in a row who recently had a family member diagnosed with cancer, or recently had, you know, a miscarriage, or something that is relevant to what you're talking about, could be a very challenging thing for that whoever it is that you're asking to be part of the case. So that's always been a consideration of mine, and I've tried to avoid putting people in that situation, because it just makes them not want to come back and teach or not want to come back and help.
For my case, it was a little challenging just because when you're talking about diversity and equity, it's just hard to find SPs that represent those groups and that would be comfortable doing it. So for my case, I actually ended up being the patient. And I had a couple of family members because I could not find anyone in time. But later on, I discovered that I reached out to the local mosque, and they have a bunch of like college students who are interested in this and who would volunteer for this, which was nice. We have limited funding for this part, but for the rest of the cases, like we got nurses or nursing students as SPs before. I just transitioned from institute. So my previous institute, they had the company that they hire through the same thing. It's like, it would be like a retired nurse or retired tech or someone with a little bit of medical background.
And then for us, we don't have a very large budget, and a lot of our sims end up being kind of like filling in for gaps in the like conference schedule. So we end up having to like scramble and use our residents who don't really want to necessarily like participate like as a like learner in the sim. We'll kind of like quickly bring them up to speed, and then they kind of like plug in to be the family members. But we've been applying for some grants to get some money to hire standardized patients through the medical school.
Right. Anyone else? Anyone with any questions for our panelists?
Hey, my name is Mike. Thank you guys so much for sharing your cases. I wanted to ask a question. I think a lot of your curriculum are related to palliative care, but also just for communication in general. I think it is a really important topic to teach, and I haven't really had a lot of experience incorporating it into my sims. But what I'm more used to in terms of just general medical knowledge is, you know, for a medical sim, you'll kind of have a core base of skills that you want to make sure that you've taught your learners or your residents at the end of your session. But I'm imagining that it might be a little bit more difficult to have kind of a more concrete, kind of standardized set of actions that you really want your learners to accomplish in a specific way, which also might be because there might be different ways of talking to patients about certain things. So I guess my main question is for those of you who are kind of creating the educational content behind the simulation, especially for the debriefing, where do you guys get your material from to kind of help teach your residents? I heard also you're kind of collaborating with palliative care teams. So do they have kind of established curricula that you're sort of going off of, or is there literature search, or how do you guys kind of get that information?
I can go first. So in terms of creating this, the entire curriculum isn't only simulation, but I did also create the rest of the curriculum. So yeah, to start with that, we did a lit search and looked at other published needs assessments and EM palliative care curriculums that are out there. In terms of trying to become like the content expert that you kind of want to be for communication skills, I personally have done some training. So I've done some faculty development related to palliative care. I also have taken a few courses through Vital Talk, which, you know, I don't work for them, but I really highly recommend it if you're interested in kind of developing this skill for yourself. They have a course called Mastering Tough Conversations, which is like a 2 or 3 day course. I forget exactly. And it's like 6 hours long each day. It's really good. You come out of that feeling way more knowledgeable about communication skills. And even after doing that, I felt much more able to teach these communication skills. And then they also have a faculty development course, which is more comprehensive. It takes place like you do another 3-day stretch, which are full days. Then there are some like asynchronous learning, and then 4 months later, you do 3 days again. And so that is like, it's a faculty development course to teach you how to teach this stuff. So I've done both of them. Again, I'm not employed by VitalTalk, but I think that the courses are great. So if you have funding for it or CME or anything, I thought it was a really good investment, especially the first one, Mastering Tough Conversations. That one is more affordable. I can't remember exactly how much it was, like maybe $500. But coming out of that, I felt like I had such a more solid understanding about all of these communication skills to be able to then go on and teach them to my residents.
And then for us, Monty has a palliative care fellowship. And so the palliative care attendings who we were kind of collaborating with all had like kind of like frameworks that they used to teach their fellows how to like address like goals of care conversations, how to talk about like values, and how to talk about like end of life and all these things. So we would kind of meet with them like the week before we knew a case was coming to kind of like go like kind of like hit through all the points of, you know, like what is like the like best way that they teach their team how to do these talks. And then when we would do the debriefs, you know, we would kind of go through like, this is like a guide to help you do it. But ultimately, like a lot of communication is very like individualized and everyone's going to have their own style. And we would try to utilize whoever was like the standardized patient to kind of like help give their like feedback with like how they felt in the moment. Like, did they feel supported? Did they feel like their needs were heard? You know, and kind of help bring it in that way. Just try to help give everybody some tools that they could have in their pocket, but knowing that it wasn't like this is the way to do it. Like how like some of the medical stuff is very like black and white, like this stuff isn't.
I put the VitalTalk link into the chat for people who are interested. So we probably have time to do 1 or 2 more questions. Anyone else with a question for our panelists?
Hi, I'm Anna. I have a quick question. In regards to those of you that included like religious aspects in your cases, did you like consult with members of that community at all just to kind of like avoid your own like unconscious bias and things like that? Or kind of how did you navigate that area of the cases?
Yes. I did reach out to the local like imam priest for like the hospital, like the on-call religious person for the specific religion, and I walked with them through the case and like, hey, do you think like this is reasonable? Like, do you think like there's any form of like unconscious bias here? I also reached out to students from like not EM students, but like Muslim students who were patients or Muslim patients. Like just run them through the case, like, hey, is this relevant to you? It's nice if your institute or hospital have like a dedicated person, because people can get a little uncomfortable if you're like showing them like especially if they don't have any medical background, like showing them like this case, they can be a little biased, depends whatever culture they're coming from. And I also did a lot of research, literature review on this to see what's out there. There isn't much in emergency medicine, but there are plenty of stuff in palliative care. There are plenty of stuff in peds, in family medicine. So I just borrowed a few concepts from there as well.
Yeah, I'll say my case was based on a real patient that we had. So during that time, it wasn't my patient. I was working this day when a patient came in though and was helping. And so we have an internal medicine attending who kind of specializes in this area. So we reached out to her to get help with the management, and she sent us also a lot of resources, which we used in order to write the case. And then I also tried to do extensive lit review, and there is not a lot about, I feel like even just medical management of severe anemia and Jehovah's Witness patients. In my lit search, I was finding stuff that's from like the 90s and early 2000s. So there is certainly a lot more work that could be done in this space.
And I think your question also applies to any community that may be marginalized or have the potential for unconscious bias. An example that I can give would be we have a diversity in resident education subcurricula that extends throughout our simulation curricula. And that communication group encompasses LGBT care, several different, potentially challenging gender or race related issues. And for each one, we elicited the opinion of one of our educators. So there's at Rush, there's a gender affirming clinic. And so I spoke with one of our psychiatrists, as well as a community member who's an educator within that clinic, to make sure that, again, we were avoiding unconscious bias and portraying the patient in as reasonable a way as possible. If we didn't have someone that was able to come and help us with that. Great question.
Yeah, I think we have time for one more if anyone has another question.
I had one more quick question if I'm allowed to ask.
Yeah, of course.
I'm imagining, especially for communications like cases like this that might be in some ways a little bit more subjective and kind of a little bit more personalized. I'm wondering if during you guys' simulations, there may have been some learners who you felt were maybe not as empathetic or kind of quite catching the learning objectives in the way that you might have wanted them to, and how you might have handled giving them feedback or debriefing them during the case. Because I'm sure that there is a higher potential for maybe your learners taking it a little bit more personally, or also maybe being a little bit less resistant to feedback if they feel like what they were doing is kind of their style of doing things. I'm curious what you guys if you guys had experiences like that, or if everyone was already kind of on board.
We had like a little bit of resistance from some of the residents who felt like it was like taking away from their sim time with more like medically like relevant cases. And so when I would get that vibe from them, I would start the debrief by talking about like how important this information is to us and how often we're having these discussions with our patients, and the fact that we're holding patients in the ER for 24 plus hours routinely. And a lot of them are ICU holds or ICU rejects who are at the end of life. And then they're like, oh yeah. And then they're like, okay, fine. And then they kind of like buy into it. But we had some people who were not as enthused as others.
I think there's two debriefing skills that are important for evaluating or exploring that exact situation. And the first would be, what's their frame? So as you're debriefing this learner, tell me about your, the way you were interacting with the patient. And then it just elicits from them, oh, well, yeah, I wasn't taking it seriously. Or, man, this was a really hard case and I'm worried that I messed something up. Those two responses are drastically different in how you may need to then debrief the learner. Because the first one that was like, oh, I did great or whatever, has no idea that they did poorly. Or someone that wasn't engaged, you could say, okay, well, they weren't engaged. I'm not going to give them the same type of feedback as I would the person that did the best they could and really messed up anyways. That person is more open to learning. So finding their frame, and then almost regardless, I might use an advocacy inquiry approach. I noticed that you said this word. I'm worried that if you said that word in a clinical scenario, it may really result in some emotional challenge for the family or patient. How do you see it? That like 3-step approach, if any of you are familiar. And that is a way of really like putting them on the spot in a way that they're like, oh, somebody noticed that thing that I did, and now we need to talk about it. And it's ideally in a non-judgmental way, but also a really good way to open up the conversation that's challenging for us to start.
Yeah, I definitely agree with what you've said. I luckily had most people were on board with why we were doing the sim and thought it was valuable. In terms of, resistance to feedback, that happens sometimes anyway. Something that I was asking pretty often was sort of like looking back at that conversation, is there anything that you might change or do differently next time? And then saying like, let's brainstorm some ideas for phrasing. Because I think a lot of communication skills is like finding the words that don't feel awkward when they come out of your mouth. And, making your own phrase. It feels like you, but you're also kind of doing what's recommended. So, and then I was also having, because I have 3 people in the debrief with me at a time, having them each practice it. Like, I know that you guys might say the same thing 3 times. I just want you each to come up with a version of it and say it to me so that you kind of just get more comfortable doing this. So asking them to reflect on what they might do differently next time. And then saying, I'm going to ask everybody to come up with a headline or whatever it is that you're trying to emphasize. I felt like also was engaging for the debrief as well, and made people feel more like they expected that I was going to do this. So then they didn't feel as bad about getting the feedback, if that makes sense.
That's excellent. Thank you.
All right. Well, I want to thank all of the panelists. It was such a good discussion, and it was awesome seeing everyone's cases. I do want to advertise our next mentor hour session is going to be on March 8th at 4 p.m. Eastern time. So 3 p.m. Central, and we're going to be talking about the grant process and what different like opportunities there are out there. All right. Well, thank you, everybody. I hope everyone has a good rest of the night.
Thank you.
Thank you.